Dr. Arie Perry is a professor at the University of California in San Francisco, where he serves as the Director of Neuropathology and the Neuropathology Fellowship Program. He received his MD and residency training at UT Southwestern in Dallas, Texas, followed by surgical pathology, neuropathology, and molecular cytogenetics research fellowships at the Mayo Clinic in Rochester, Minnesota, where he worked closely with his mentor, the late Dr. Bernd Scheitauer. His interests have focused mostly on classification, grading, and molecular characterization of both adult and pediatric brain tumors. He has authored over 600 publications and participated as an editor for the WHO 2016 and 2021 5th edition CNS tumor classification updates, as well as an author in 10 of the 5th edition WHO classification schemes. He has also served as a chief editor for Brain Pathology, which is the official journal of the International Society of Neuropathology, the Practical Surgical Neuropathology Textbook, 2 editions, and Greenfield's Neuropathology, 2 editions. Dr. Perry maintains an active consult service and is a frequently invited lecturer. He also enjoys creative modes of teaching, making use of his longstanding passion for music. In this respect, he has been featured in several media stories for using neuropathology songs in medical education, including CD recordings and YouTube videos. I will now turn it over to Dr. Perry.
Thank you, Angelica. I appreciate that. And thanks to the organizers for inviting me to give this important topic as a lecture. Let me share my screen and get this going. Hold on, bear with me. Okay, so hereditary tumor syndromes, I think, is an increasingly important topic, and I think some of you may be surprised how often we're the first to suggest some of these syndromes and really the first to make these diagnoses. And of course, it has tremendous implications not only for the patient, but for the family as well, and in some cases changes the therapeutic strategy as well. So I have no financial relationships to disclose. And you've already seen these objectives, so I will go past that. So this is a table of the genetic syndromes that were covered in the most recent 5th edition of the WHO that just came out in 2021. And you'll see the CNS, or the nervous system, is one of the most important, or one of the most commonly involved organ systems in these syndromes. And so we actually have 20 listed here that commonly involve the nervous system. And notice these first 12 were included in the 2016 version, but these additional 8 are new in the newest WHO, which just, I think, goes to show you how rapidly the field is evolving. And just some basic concepts is that these often have a really wide range of phenotypes and penetrance. And as I mentioned earlier, there's implications not just for the patient, but for the entire family. And so often really genetic counseling is important to get these people involved early on. And really these are often highly complex disorders, and patients do best when you have a dedicated multidisciplinary team involved in these, fairly unique disorders. Most importantly, though, I would say is that we as neuropathologists are not infrequently the first ones to get some of the most important clues to put together these diagnoses. And I'll show many examples of that. And nowadays that we're doing next generation sequencing fairly routinely, sometimes the first clue is from those as well, and I'll show examples of that as well. So I had the honor of being the main editor for this section in the latest WHO. And so in the introduction, I thought what I would do is put together a table that does the opposite of what we usually do. what we usually do is list the disorder and then all the different tumor types under the disorder. But here I took it from our viewpoint as neuropathologists and listed what are the tumor types that should always make us think of a hereditary tumor syndrome and suggest further workup. So I'll let you look at that on your own. We'll certainly go through some of these, but not all of these today. And I'm going to focus on some of the lesser known aspects. So I think everybody knows that plexiform neurofibromas in NF1 are, the most common type of neurofibroma and the one that's at high risk of transformation to MPNST. What maybe is a little bit lesser known is that the intraneural neurofibromas, especially in the nerve roots next to the spinal cord, are often ones that transform to MPNSTs as well. This is actually an MRI from a single patient with NF1 where virtually all the nerve roots are involved. So certainly this is where we see MPNSTs arise, not that infrequently as neuropathologists, because this is where the neurosurgeons get involved. And one of the things that is new in the last WHO is this kind of intermediate category in NF1 cases that's called AANP, or atypical neurofibroma, or neurofibromatous neoplasm of uncertain biologic potential, kind of a mouthful, not to be confused with Anubis, the Egyptian god of the afterlife. But this was something we put together in a consensus group at the NIH with both soft tissue pathologists and neuropathologists. It's not really based on new data, but just kind of our expert opinions of what to do with some of these tough to diagnose cases. And I think we're seeing them more and more often because of surveillance of these patients is increasing. And so this is an example from the actual paper showing a patient with NF1 that was followed with this plexiform neurofibroma from age 9 to age 15. And you see these two distinct nodules that are growing within the neurofibroma. So these are the types of things that tend to get biopsied, or if one is hot on a PET scan, or a change in clinical behavior with increased pain. Those are all things that tend to get biopsied. And so we're seeing these in evolution at an earlier stage, and we're seeing these ANPs and low-grade MPNSTs, I think, more often than we used to. So I won't go over the details. These are the criteria that we published. One of the criteria for ANP is loss of neurofibroma architecture, and I just would point out that this could be either due to fascicular growth on the histology or a useful immunostain is CD34, which tends to show this lattice-like pattern of staining that's lost in ANP, or at least a subset of ANPs. So let me show you an example of one of these cases. This was an NF1 patient with a plexiform neurofibroma that was biopsied, and the ordinary neurofibroma part is out here on the right, and you see there's something that looks a little bit different here on the left. And at higher mag, you see these were photographed at the same magnification, and you can see that on the ANP side, there's increased cellularity and certainly increased cell size and atypia, but it's somewhat on the fence. It's, should you call this a cellular neurofibroma or ANP, which is really considered kind of a pre-malignant or early malignant transformation of a neurofibroma. Well, one of the other useful stains besides CD34 is P16, so I just wanted to make sure you knew about that. And the reason is that already at this stage, many of these cases have homozygous loss of the CDKN2A gene on chromosome 9, which leads to loss of P16 expression. So you can see there was that neurofibroma part. Here's the ANP part, certainly decreased level of expression. And at higher mag, you see there's fairly extensive P16 expression in the neurofibroma, and what I would consider complete loss of expression in the AANP. And we always get these perivascular little thin spindled cells. So I think these are normal cells, and all the tumor cells really are negative for P16 in this example. So this really helped us to go ahead and call this AANP rather than cellular neurofibroma in this particular case. In NF2, there's not a whole lot that's new. There certainly are a few things, but these are often cases that the neuroradiologist can make. And so already with bilateral vestibular schwannomas, as you know, that's enough by itself to call NF2. This was a case that had multiple neurofibromas as well. And then the thing that often people forget is the spinal cord ependymoma. For whatever reason, they often occur in the cervical spinal cord or cervicomedullary junction around this region. And here, the maybe semi-new thing to remember is that if you're suspicious of NF2 and you get a schwannoma, and when should you be suspicious? Well, if it's a young patient, let's say under the age of 30, one with kind of a long segment of nerve involved by schwannoma or little multinodular growths on a nerve, these should all make you think of schwannomatosis or NF2. And with the INI1 stain, what we often see in these cases is a mosaic pattern of staining. So this is not entirely sensitive or specific, but one more clue or one more tool you can use to say, really I'm suspicious of schwannomatosis or NF2 in this case, and maybe additional studies should be done. One thing that is new, just give me 1 second here, is that we've known for a long time that in schwannomatosis, the main gene that's involved besides NF2 is SMARCB1, but now there have been a couple of other genes that have been reported. So LZTR1 and DGCR8 also involved in rare cases of schwannomatosis. So going down the list of von Hippel-Lindau disease, everybody knows about the association with hemangioblastoma, so I'm not going to talk about that. The rarer association that people often forget, but we see as neuropathologists, is endolymphatic sac tumor of the inner ear. And although these are rare, about 40% of what seemingly at first are sporadic tumors end up being associated with von Hippel-Lindau disease. So anytime you see this tumor, always mention the possibility of von Hippel-Lindau disease. And there's a diagnostic pitfall with these because they can be very papillary and look a lot like a choroid plexus papilloma, as you can see here, or sometimes they have these little colloid-filled cysts that are not that prominent in this example. And the immunostaining profile between those two tumors is largely overlapping. So how do you tell them apart? Well, really the big clue is bone involvement. So choroid plexus tumors really do not invade bone. So if you see this is not a choroid plexus papilloma. And really, again, don't forget to look at the imaging. So here's an example that invaded into the cerebellopontine angle. And certainly you could get a choroid plexus papilloma in that area, but notice the bone involvement here. So these arise from the inner or middle ear. And so here on a CT scan, you can see the bony destruction. Choroid plexus tumors really don't do that. Similarly, the imaging is incredibly important in many of these disorders. So in tuberous sclerosis complex, due to TSC1 or 2. You may get a sample from a SIGA or subependymal giant cell astrocytoma or from a tuber. And, in florid cases, really the diagnosis can be made on imaging. So this is a patient with not only a SIGA, but also these candle gutterings under the surface of the ependyma along the ventricle, and multiple tubers that, if you look carefully, here's one there, here's one there, here's another one there. The more you look, the more of these you see. So the imaging really is critically important on these. Another one where the imaging is highly, highly characteristic is Lermite-Duclos disease due to P10 germline variants. And the thing we see as neuropathologists is these dysplastic gangliocytomas of the cerebellum. And they have this very typical tigroid appearance on T2 weighted imaging, as you see there. But I will tell you that's not absolutely specific. I have seen cases of medulloblastoma or diffuse gliomas with a lot of CSF spread that can mimic this appearance. I'm not going to dwell on it, but as you know, the main histologic pattern we see is this conversion of internal granular cell layer neurons in the cerebellum into these large dysplastic ganglion cells, as we see here. So the dysplastic cerebellar gangliocytoma is one of the pathognomonic features of Lermite-Duclos disease, mainly when it occurs in adults. So almost all of these in the adults end up having a germline P10 variant. For some reason, when patients present in childhood, it's less consistent. So it could be something else in childhood. All right, so those are just some pearls that I wanted to kind of throw your way. And then for the rest of this, I'm going to show you some interesting cases that we've encountered over the last few years that kind of drive home these points, and maybe show you some of the less common disorders. So this is a 12-year-old boy with intermittent headaches for a year. He was initially diagnosed with migraines and treated for that, but suffered some head trauma while playing some sort of sport, soccer or whatever. And on exam was found to have some papilledema, so that bought him an MRI, and a posterior fossa mass was identified on neuroimaging. Okay, this is getting stuck for some reason. I don't know why. I can't advance this. Let me stop sharing for just a second and then bring it right back up. Okay, it is stuck. Very strange. Let me start it over. Okay. I don't know what happened there, but anyway, this is our tumor on imaging, and you can see it's partially enhancing.
We can't see your slides.
You can't see the slide. Okay, so thanks for letting me know.
I have a backup copy as well if yours continues to not work.
Let me just try it again. Share the screen. If that doesn't work, then you can certainly go ahead. Are you seeing it now?
Yeah, I see an MRI.
Yes.
Yeah, okay, good. Sorry, so this is the imaging, partially enhancing cerebellar mass. And on pathology, it's a small blue cell tumor with some vague nodularity. Certainly in this location makes you think of medulloblastoma. This is an apoptotic lake, collection of apoptotic cells, and indeed had a lot of kind of anaplastic features with very large atypical cells, some cell wrapping, high mitotic index. Focally, we had these large pink cells, and usually our trainees now automatically say rhabdoid cells, but the other thing to also consider is what rhabdoid cells were named after. So rhabdo, these could be rhabdomyoblasts, but they were interesting. So we did a reticulin, and most of it was reticulin poor, but at least focally it had the typical pattern, nodular, the pattern of desmoplastic nodular, as you see here. Synaptophysin also had, at least focally, that pattern of staining within the nodules and not so much in between the nodules. And indeed, on Desmond, these rhabdomyoblasts were positive. So these are the fairly rare foci of myogenic differentiation in this medulloblastoma. And sometimes the immunostaining can be really deceiving in these medullomyoblastomas or medulloblastomas with myogenic differentiation, but this one was fairly clear. So YAP1 was strongly positive, GAB1 was strongly positive, so really suggests SHH activated medulloblastoma. P53 was negative, but notice it's completely negative. There's not any positive cells here at all. So this is less common, but certainly one of the patterns we see with P53 mutation. So on the initial diagnosis, we call this a medulloblastoma large cell anaplastic histologic type with focal myogenic differentiation, SHH activated and likely TP53 mutant grade 4. And because this was a consult case, we recommended doing a paired tumor and germline NGS and DNA methylation profiling, both of which were done in this case. And so on our UCSF 500, what you see on the germline, there's a mutation of P53 that's heterozygous. So this is Li-Fraumeni syndrome. And in the tumor, it goes to nearly 100%. So the second allele has been inactivated. And looking at the copy number alterations, you get really a sense that this is genomically unstable with lots of chromosomal alterations, including loss of 17p, which is how that second allele of P53 was inactivated in this particular case. So on DNA methylation profiling, indeed, this fit with a SHH activated medulloblastoma. It was the subclass A, which generated a comment that this includes those cases that arise in Li-Fraumeni syndrome, typically in children of between the ages of 8 and 16, often with large cell anaplastic features, all the things we have in this particular case. And here on the copy number plot, you can just see how genomically unstable this tumor is. So our final diagnosis in this case was a medulloblastoma large cell anaplastic type, focal myogenic differentiation. Indeed, we confirmed it's the SHH activated and TP53 mutant molecular group, which has a significantly worse prognosis, but importantly, arising in the setting of Li-Fraumeni syndrome. So before I discuss Li-Fraumeni syndrome, let's look at a second case. This is a 3-year-old boy with no significant past medical history and presented to the local ED in status epilepticus. Imaging showed this large left-sided intracranial mass, which you can see here. So quite large, contrast enhancing, seems to show this kind of centrally necrotic area. A little hard to tell exactly where this tumor is arising from, but certainly looks pretty worrisome for a malignant neoplasm. And on histology, it certainly looks like a poorly differentiated neoplasm as well. You see the necrosis, somewhat of a small blue cell appearance in some areas. Other areas, vaguely epithelioid, certainly very pleomorphic, mitotically active. Some very bizarre looking cells and atypical mitoses. So we did a large panel of immunostains, and I'm just going to show you a couple of them. It's keratin positive with this kind of paranuclear dot-like staining pattern, not entirely specific, but commonly seen in choroid plexus tumors to have that pattern. And transthyretin, another marker for choroid plexus, was extensively positive in this tumor. So it fit with a choroid plexus carcinoma. And in this case, our p53 stain was diffusely and strongly positive. So this is the more common pattern that we see with p53 mutant tumors. So we call this a choroid plexus carcinoma and suggested that it could be, again, part of Li-Fraumeni syndrome, which was confirmed by next generation sequencing. So again, we have a germline, in this case, p53 mutation at an allele frequency that's consistent with heterozygous mutation that in the tumor became nearly 100%. So the second copy was lost somehow. In this case, I think it was by copy neutral LOH. But the surprising thing was we actually saw another germline mutation in the mismatch repair gene MSH6. So Li-Fraumeni and suggesting Lynch syndrome as well, although this one was not involved in the actual tumor. So very interesting case, choroid plexus carcinoma grade 3, arising in the setting of Li-Fraumeni syndrome. This patient was treated with chemotherapy, but radiation therapy was withheld because we know that patients with Li-Fraumeni syndrome often develop secondary malignancies anywhere that you radiate. So this had an effect on the therapy of this patient. Both of the parents got tested, and neither one of them had a germline p53 mutation, so this is a new mutation in the patient. But interestingly, the father did have the identical MSH6 mutation consistent with Lynch syndrome. And our speculation was that this Lynch syndrome mutation in MSH6 caused some genomic instability during spermatogenesis and led to additional mutations, in this case, a p53 mutation on top of the MSH6 mutation. So Li-Fraumeni syndrome, as you know, involves many tumors throughout the body, a variety of malignancies. You probably remember any childhood case of adrenocortical carcinoma is virtually pathognomonic of Li-Fraumeni syndrome. Brain or CNS malignancies are seen in about 16% of these patients with Li-Fraumeni syndrome and come in a variety of flavors, as you've seen with these two cases. So one that's not that common, but strongly associated with Li-Fraumeni is the choroid plexus carcinoma. So anytime you have an infant with choroid plexus carcinoma, you got to think of Li-Fraumeni syndrome. Do the p53 stain. Often in the syndromic cases, they're very strongly and extensively positive. So suggest this association. There are a couple of diffuse gliomas associated with Li-Fraumeni. One that's seen in young kids that tends to be IDH wild-type high-grade gliomas, often with NF1 mutations and NMYC gene amplifications. And then there's a low-grade glioma that occurs more often in young adults. These are IDH mutant astrocytomas and have an overrepresentation of non-canonical mutations such as R132C and R132S. And then we showed an example of medulloblastoma, SHH activated and P53 mutant, most often a quote middle-aged kid, so not an infant or young child, not a adolescent or adult, but in between. And many of these have large cell anaplastic histology. So case 3. This is now a 2-year-old boy with macrocephaly, developmental delay, poor balance, and 3 to 4 weeks of headaches. And there was a very large heterogeneously enhancing midline posterior fossa mass identified, which had an interesting imaging appearance, as you can see here on T2, but also on post-contrast T1, as you see here. This pattern, you can almost see nodules at this, even on the imaging. So this sometimes is described as a bunch of grapes, and it's actually a clue to the diagnosis if the radiologist is particularly astute. Almost always in infants or very young children. And here you see what some of those large nodules look like. You can see one of these very large irregular nodules that seems to, in this otherwise small blue cell tumor, seems to be areas, pale islands, but very large pale islands. And when you look at higher magnification, there's really extensive neuronal differentiation, even more than usual here. So lots of neuropil, lots of neurocytes, and even ganglion cells in this particular example. And then other areas look more like conventional desmoplastic nodular medulloblastoma, like what we saw a little bit in the last case, but without the large cell anaplastic features. And then this kind of streaming or linear arrays, also very common in the desmoplastic nodular medulloblastomas. So there was less of the primitive small blue cells in this case, but certainly we had areas of small blue cell tumor. It is indeed a medulloblastoma. And on reticulin, you see these very large nodules going all the way down to more conventional looking small nodules. Same thing on the synaptophysin. And beta-catenin showed no nuclear expression, but GAB1 was strongly positive, again fitting with the sonic hedgehog activated molecular group of medulloblastoma. So our initial diagnosis was medulloblastoma extensively nodular, SHH activated and likely P53 wild type. And we did the next generation sequencing and found, again, paired germline and tumor, and found that there was a germline SUFU mutation, as you see here, and it goes to nearly 100% on the allele frequency when you look at the tumor. So this is one of the variants that's associated with Gorlin syndrome, or nevoid basal cell carcinoma, commonly seen in infants and very young children when we see it. As you can see in this paper, the germline SUFU mutations are responsible for a high proportion of the desmoplastic medulloblastomas in kids under the age of 3 years. So if you look at Gorlin syndrome as a whole, patched mutations are actually more common, but the risk of getting medulloblastoma is much higher with the SUFU mutations, and so it's actually more common that we find these SUFU cases. And they can either be conventional desmoplastic nodular or extensively nodular, as we saw in our case, typically SHH activated, P53 wild type. And this is another tumor type where radiation therapy is typically withheld because these patients get a bunch of basal cell carcinomas anywhere they get radiated, and can get other secondary tumors, including meningiomas as well. So in the patched variants of Gorlin syndrome, there's often a variety of other malformations that seem to be much less prevalent in the SUFU cases. So don't forget, in addition to medulloblastomas that have a variety of hereditary tumor syndromes associated with them, the ATRTs also have that, if maybe even more so. And about 25 to 35% of ATRTs arise in the setting of rhabdoid tumor predisposition syndrome. Most of these are in patients under the age of 1 year old, and they're predisposed to not only ATRTs, but malignant rhabdoid tumors in the kidneys and soft tissues and other parts of the body. Most of these are the RTPS type 1 associated with germline variants of SMARCB1, which encodes INI1. Very rarely, they're SMARCA4, the RTPS2, which encodes BRG1. So, of course, we have these two immunohistochemical surrogates, but they don't really tell you, they can't distinguish a sporadic from a familial form of ATRT. So in any young patient with ATRT, they really should be doing germline testing or ruling this syndrome clinically, ruling it out clinically. All right, so case 4 is a 60-year-old woman with right-sided hearing loss and this 2.3 centimeter enhancing mass in the prepontine cistern, which is this curious little tumor you see here. For the most part, looks extraaxial, so you might think perhaps this is arising from the meninges or perhaps a cranial nerve. It's a little hard to be sure. And very interesting pathology. So you see these sheets of very large pink cells with vesicular nuclei and big nucleoli and lots of inflammation in the background. You can see it at higher magnification, so I think this definitely qualifies as cherry red macronucleoli. And then at least focally, you see these histiocytes with pigments that look a lot like melanophages. So stains were done by the referring pathologist, and this was SOX10 positive. They had some sort of melanoma cocktail. I can't remember if it was HMB45 and melan A, but it was certainly positive in this case. Collagen 4 showed a somewhat increased intercellular deposition, but surrounding groups of cells rather than individual cells for the most part. And BRAF V600E, as you might see with metastatic melanoma, that was negative in this case. BAP1 was retained, and a subset of primary meningeal melanomas will lose BAP1, not all of them. And then we're lucky at UCSF that we have this stain available for PARCAR1A, which in this case was retained in the inflammatory cells, but you can see completely lost in the tumor cells. So PARCAR1A is associated with Carney Complex. So we went back and said, look for additional features. Were there any other findings in this patient? And indeed, they found there was a prior history of cardiac myxoma. So this is really interesting. So our final diagnosis was malignant melanotic nerve sheath tumor arising in the setting of Carney Complex. And these are mainly due to germline mutations in PARCAR1A, about 70% of the cases. The rest are a gene or genes that are not well characterized at this point and usually associated with milder disease. The types of lesions that you get in Carney Complex are mostly these pigmented lesions or myxoid lesions, myxomas in the skin, atrial myxomas, things like that. And here are some of the diagnostic criteria, clinical criteria. And we had two of the major diagnostic criteria, cardiac myxoma and malignant melanotic nerve sheath tumor, so enough to clinically diagnose this as Carney Complex. And although germline testing was not done, this surrogate stain with PARCAR1A gene is a pretty good surrogate for loss of this gene. So as you probably know, these used to be called melanotic schwannomas and used to be considered a variant of schwannoma. But there was this nice paper by Andrew Fulp's group at the Mayo Clinic showing these really are clinically, genetically, biologically very different disorders. And so now both in the CNS WHO and in the soft tissue WHO, these are considered their own tumor type. And they're often seen in paravertebral nerve roots. So neuropathologists are often the ones to see these, not always. But unlike schwannomas, certainly there's a very high recurrence rate and even metastatic rate. So these really are malignant clinically. And they said in this paper, loss of PARCAR1A expression by immunohistochemistry suggests a link to Carney Complex, even when the history is otherwise absent. So always think about this in this rare tumor type. So case 5, 15-year-old girl with known NF1. This was a really challenging case. Had a prior posterior fossa diffusely infiltrating astrocytoma, grade 2, 11 years ago. Almost certainly that's not correct, and it was a pilocytic astrocytoma. But the tumor that we got to see was this left parietal high-grade tumor that was called gliosarcoma, actually by me, 4 years prior, and now shows evidence of recurrence. And here's what it looks like. Very anaplastic looking cells, these fairly interesting, distinctive, very brightly eosinophilic granules in some of the cells that you see here. At that time, I didn't really know what that meant, but I do now. Reticulin was strongly positive in between the cells, and that's consistent with a sarcoma or sarcomatous neoplasm. And GFAP was negative in this recurrence, but showed you that there is indeed an infiltrative component in the adjacent brain, and I think this is why I called it gliosarcoma originally, and I thought probably this was the best diagnosis at recurrence. Desmond was focally positive. We could certainly see that in gliosarcoma. So I initially called it a poorly differentiated neoplasm with features suggestive of gliosarcoma. We did the next generation sequencing. Here's the germline NF1 mutation confirming that clinical diagnosis of NF1. But we actually have two mutations in the DICER1 gene inactivating this gene somatically, P53 mutation and a second NF1 mutation, and then another kind of pattern of genomic instability here. So this actually is diagnostic of a completely different tumor type. Primary intracranial sarcoma, DICER1 mutant, clinically recurrent. This is one of the new entities in the WHO 2021, and is most commonly associated with patients with DICER1 if it's a familial tumor. But we have seen these rare cases associated with NF1, as in this case. So threw us off, even though it was an NF1 patient. These are pleomorphic, spindled, primitive, small, round blue cells, and these often, not always, but often these prominent eosinophilic granules. That's one of the clues to the diagnosis. They often have limited myogenic and or chondroid differentiation. And as in this case, they can mimic astrocytic neoplasms, especially gliosarcoma, because of their focally invasive growth pattern. The ATRX loss that's common in these, P53 overexpression is common, and H3K27ME3 loss. All of these are common in these tumors. So a bit of a curveball. These are all the possible CNS manifestations in patients with DICER1 syndrome. The most common would be metastatic pleuropulmonary blastoma. I've seen quite a few of these primary intracranial sarcomas with DICER1 mutation. There's a subtype of pineoblastoma. There's a new second type of embryonal tumor with multi-layered rosettes with DICER1 mutation, pituitary blastoma, and ciliary body meduloepithelioma. So here's the last case, 9-year-old boy, 2 to 3 weeks of headaches, nausea, and vomiting, 5.4 centimeter solid cystic right temporal lobe mass that you can see here. Post contrast, you can see partially enhancing there. Clearly a malignant neoplasm with very bizarre multinucleated giant cells, necrosis, high mitotic index, atypical mitoses, GFAP at least partially positive, but negative for both IDH1 and mutant histone 3 at the G34 level, but associated with ATRX loss and P53 overexpression. So I'll tell you, whenever I see these giant cell high-grade gliomas, especially in young patients or kids, I always add the 4 mismatch repair enzymes. And in this particular case, there was loss of PMS2, not only in the tumor, but in fact, there was no staining in endothelial cells or any normal cells. And we did this stain twice and got the same results. So this is highly suggestive of what's called constitutional mismatch repair defect. And here's the NGS. We'll talk about what ultra hypermutation means, but again, the ATRX, NF1 is common, P53, a whole long list of mutations, some of which are hard to tell whether they're driver mutations or passenger mutations. But POL is another DNA repair enzyme that often is associated with this and then causes complete inability to repair certain types of DNA damage, and that's why we get this kind of pattern of ultra hypermutation. So in the germline, there were 2 inactivating mutations of PMS2. That's by definition constitutional mismatch repair defect. One was an intragenic deletion, the other was more of a standard mutation. So it's a diffuse pediatric type high-grade glioma with giant cell features, both H3 and IDH wild type, arising in the setting of constitutional mismatch repair defect syndrome, grade 4. And this is the pattern we see, or probably many people see more often with Lynch syndrome, where there's retained expression in the normal cells, but loss of expression in tumor cells. So these are autosomal recessive, unlike Lynch syndrome, which is autosomal dominant. It's biallelic inactivation of an MMR gene. And because of this, it's particularly common in areas where parental consanguinity is common. So, for example, first cousins marrying each other. And they often have cutaneous cafe au lait macules. So clinically, a number of these cases are misdiagnosed as NF1 rather than CMMRD. So this ultra hypermutation pattern, greater than 100 mutations per megabase, and these are high-grade gliomas. They don't respond very well to temozolomide, and often the first line of therapy for these is immune checkpoint blockade. So these are the disorders I didn't cover. I did talk about this one in my meningioma talk a few months ago. But a growing number of these syndromes of the CNS and or PNS are being recognized, and we as neuropathologists are not uncommonly the first ones to get the clues to these. And so really be vigilant and suggest these whenever you see anything that looks like a possible syndrome. Further clinical workup, germline testing, and often a referral to a genetic counselor should be considered in these cases. So at this point, thank you very much. I will stop. And
Thank you. That was beautiful.
happy to take any questions.
Yes, at this time, we're going to move on to Q&A. You can submit your questions in the chat box, or you can unmute to ask a question. When you submit a question via the chat box, please ensure the message is to everyone so that the presenters and attendees are able to see the question. To unmute, select the microphone in the lower left corner, and once you've asked your question, please remute to avoid background noise. So if you'd like me to read, do you want me to read the questions, Dr. Ferry? Or
Sure, go ahead. Yeah, that's probably easiest.
Yes, the first question from Mark Delvigio: have you done electron microscopy in the DICER mutant tumor to determine the nature of the eosinophilic granules?
No, we have not. I mean, often that pattern is seen with some sort of lysosomal inclusion, and that's what we kind of assume that is, although not very specific. I can't remember any other papers from the other groups where they've done that, but maybe somebody has done that. But typically they're lysosomal inclusions of some sort. We still don't really know the lineage of these. They were thought to be rhabdomyosarcomas initially, but usually the myogenic staining is only very focal or very limited, and they can be chondroid as well.
The next question from Sarah Black: can the diagnosis of AANP be rendered in a non-NF1 patient, or is the term reserved for NF1 patients only?
Yeah, that's a great question. So that paper that we put out really was specifically for NF1 patients. That's where we tend to see these kind of in-between lesions. You know, that said, in very, very rare cases, I have seen something similar in a sporadic patient, and you wonder, I assume the same progression can occur in sporadic patients, but really that paper was meant for NF1 patients.
Okay. Then I would like to go to Namita Sinha has her hand up if you'd like to go ahead.
Hi, Arie. That was excellent talk on the syndromes.
Thank you.
Causing the brain tumors. The last case that you presented of CMMRD in the glioma, do you always do PD-1, PD-L1 kind of immunohistochemistry to see if immunotherapy will be effective, or it doesn't matter?
It's really not needed. That's often their first line of therapy if we make that diagnosis. I would say in general in our gliomas, we don't do PD-1 and PD-L1. Occasionally it's requested, but there's really, in my opinion, no great data to show that in the gliomas it correlates like it does with other tumors tightly with response to therapy, with immune blockade therapy.
Okay, because we got case and we did immunohistochemistry. It was not helpful, but eventually I think patient ended receiving the immunotherapy. I have other questions as well for you. Do you always recommend performing transthyretin IST in choroid plexus neoplasm? Like, we don't have transthyretin, and sending the case for IST sometimes delays if we have papillary lesions with a carcinoma component. Do you still recommend transthyretin immunostaining?
Yeah, I mean, I guess, you do what you have, right? So we do have transthyretin, so we do it. It's not the world's most specific stain, but it tends to be strong and fairly extensively positive in choroid plexus tumor. So it's just one more piece of evidence for that. There is a more specific stain that the German group has reported. Now I can't remember what it's called, but we don't have that one. So, you do what you have in your panel, I guess.
Okay, I have one more question for you. So I get a carcinoma with a lot of poorly differentiated component, and sometimes transthyretin can be negative in those carcinomas when it is poorly differentiated. So the tumor was intraventricular in a young adult, no family history of any carcinoma in the body or Li-Fraumeni syndrome. But we did CK was positive, P53 was diffusely positive. So we ruled out all the carcinomas by doing stains. I mean, most common metastatic that could be metastatic to brain. So we rendered the diagnosis. So do you recommend methylation profiling to confirm it's a definitive or not? Because one of the patient father kind of emailed us that, is this a definitive diagnosis? Since we have no definitive marker, that was a difficult question for me, but ruling out other carcinomas.
Yeah, I would in that case, because you have at least two things that are, uncommon. So one is the age, very uncommon to get choroid plexus carcinoma in an adult. And in my experience, transthyretin is pretty rarely negative, even in very poorly differentiated tumors. So I think even in the regular cases, it's probably a good idea to do the DNA methylation profiling, because we don't have a good mutation, driver mutation or other signature alteration that says definitively this is choroid plexus carcinoma. So, but especially in the case you pointed out, I would do the DNA methylation.
Okay. One last one, sorry. So I had also atypical choroid carcinoma where I saw multiple layering, but Ki was around 5% or less. P53 was diffusely positive. So these atypical choroid plexus papilloma can also be associated with Li-Fraumeni syndrome, being P53 diffuse and strong positive.
Yeah, it's quite rare. It's quite rare for those in Li-Fraumeni, and they really are usually carcinomas. So
Okay.
again, that would be a good one to do DNA methylation.
Okay, thanks. That's all. Thank you so much, Arie.
Okay, next in the chat box, we have Joseph Fulmer. Is there any role for P16 in sporadic neurofibromas as a quick screen for CDK2 alterations?
Yeah, that's a great question. I think it works pretty well. I mean, there are cases where it's hard to interpret because it's hard to know for sure what's a normal cell and what's a tumor cell. But most of the time, if there's really inactivation of CDKN2A, it's pretty obvious on the immunostain. Now, the same is not true for all tumors. Like in gliomas, it really doesn't work well. So for some tumors, it works well, and others it doesn't. But I think in nerve sheath tumors, it's a pretty good marker. It's pretty decent anyway.
Then we still have a few questions, but I'm thinking maybe we have time for one more. So how about from Lena Young, thanks for a wonderful lecture. Have you seen DICER mutant sarcomas in adults?
I have, yeah. It can occur in adults. Yeah, good question.
Okay. I don't know. We still have a couple more. Should I go ahead?
It's okay with me. Yeah, I'm not in a hurry.
Nellie Lacus. Oh no, I'm sorry, I skipped one. Veena Rajaram, do you use loss of H3K27Me3 in AANP diagnosis?
I often will do that marker. That's a great question. If it's lost, it's not AANP, it's MPNST. Okay. Usually when you're in that diagnosis of AANP versus low-grade MPNST, it's retained. I mean, it's pretty rare. But if I saw loss of expression, that would really push me to MPNST.
And next from Nellie Lacus, should we recommend germline mutation in any brain tumor that comes back with NF mutations?
Not necessarily, because NF1 mutations are common in sporadic gliomas as well, but usually those are older patients. So, if I would say it would probably need to be a little more than that to just say automatically do it. We try on our in-house cases, we try to get as many germline as we can, just because sometimes you're surprised. So.
Okay. And then the last question, Marwa Abdul Kader, Excellent talk as usual. How can you differentiate intracranial sarcoma from other sarcomas?
It's defined by that DICER1 mutation. So you have to demonstrate the DICER1 mutation to make that diagnosis.
Okay, I believe that's the last question.
Great.
Thank you. Oh, sorry. Thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your Path LMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website within the next week. Thank you again, Dr. Perry, for an excellent presentation. This concludes the
My
session
pleasure.
for today.
Thank you.
Bye, everybody.